Assalamu alaikum. Our seminar today about knee joint radiographic anatomy. The knee joint is the largest and complex hinge type of synovial joint made up of two components, the tibiofemoral articulation between the condyles of the tibia and femur, synovial hinge joint, and it is the weight bearing, and the patellofemoral articulation between the anterior surface of the femoral condyles and the posterior surface of the patella, which is synovial plane gliding joint and not weight bearing. The knee joint is characterized by the presence of ligamentous and meniscal structures that play an important role in the stability and mobility, and it is likely to be damaged than most other joints. The movements of the knee joint include flexion by hamstrings, sartorius, gracilis, and popliteus muscles, extension by quadriceps femoris, external rotation of the flexed knee by biceps femoris and sartorius, internal rotation of the flexed knee by semimembranosus, semitendinosus, and gracilis muscles. The blood supply and innervation. Blood supply by the anastomosis around the knee joint between the branches of the femoral and popliteal vessels, genicular anastomosis. The innervation by genicular branches of the femoral, obturator, tibial, and common peroneal nerves. The components of the joints include the bones, ligaments, bursae, and muscles. Starting with the bones of the knee joint, we have the lower end of the femur, upper end of tibia, posterior surface of the patella. The lower end of the femur, it presents medial and lateral condyles. Medial condyle is larger than the lateral condyle. Anteriorly, both condyles are connected and present an articular area for patella. And patellar articular area is larger over the lateral condyle and smaller over the medial side. The rest of the articular area on medial and lateral condyles is meant for tibial articulation. On posterior aspects, condyles are separated from each other by the means of a deep and wide notch known as intercondylar notch. The notch presents medial and lateral walls. This is the patellar surface of the femur, and this is the articular surface of the patella. And these are the medial condyle and lateral condyle of the femur. Upper end of tibia, presence of two condyles, medial and lateral. Medial condyle is larger than that of lateral. The medial condyle presents a shallow articulation area for the articulation with the medial condyle of the femur, and this area is oval, while the lateral condyle is circular and presents articulation for the lateral condyle of the femur. The two condylar areas are separated from each other by the means of anterior and posterior intercondylar areas and the tibial spines. Posterior surface of the patella, it presents large oval articular area above and small non-articular area below. The articular area of the patella is divided into large lateral and small medial areas by the means of faint ridges. This is the lateral facet, and this is the medial facet, and these are the patellar ridges. Regarding the ligaments are classified into extracapsular and intracapsular ligaments. The extracapsular ligaments include the ligamentum patellae anteriorly, oblique and arcuate popliteal ligaments posteriorly, tibial collateral or medial ligament medially, fibular collateral or lateral ligament laterally, and the intracapsular ligaments include anterior and posterior cruciate ligaments, medial and lateral menisci, and the transverse ligament. The fibrous capsule attached to the margin of the articular surfaces. It is partly deficient superiorly, where the joint cavity communicates with the suprapatellar bursa between the quadriceps femoris and femur, and posteriorly, where it may allow communication with the semimembranosus and popliteal bursa. The capsule includes the tibial tuberosity and fibular head and is pierced by popliteus tendon posteriorly. The capsule blends with and is strengthened by multiple structures, including the gastrocnemius head and oblique popliteal ligament posteriorly, medial collateral ligament and external aspect of medial meniscus, and the tendon expansions of the vastus lateralis iliotibial tract and vastus medialis anteriorly, forming the patellar retinacula. This is the joint capsule surrounding the knee joint, and these are the extracapsular ligaments, and these are the intracapsular ligaments. Regarding the patellar ligament and medial and lateral patellar retinacula, the patellar ligament starts from the apex of the patella to smooth area of tibial tuberosity. It is a strong fibrous band, and it is about 8 cm length. The medial and lateral patellar retinacula are fibrous expansions of the vastus medialis and the vastus lateralis, respectively, comprising of superficial and deep layers. They are important stabilizers of the patella. Regarding the medial and lateral collateral ligaments, the medial collateral ligament is composed of deep fibers intimately related to the meniscotibial and meniscofemoral ligaments and to the joint capsule. The superficial fibers form a band from the femoral medial condyle to the medial aspect of the proximal tibia. The lateral collateral ligament complex is composed of 3 layers: an outer layer with the iliotibial band anteriorly and the biceps femoris tendon posteriorly. Middle layer is formed by the cord-like fibular collateral ligament, and the deep layer is formed by the popliteus tendon. This is the medial collateral ligament, and this is the lateral collateral ligament. Arcuate ligament. It is a Y-shaped thickening of the posterolateral capsule, which arises from the fibular styloid and divides into medial and lateral limbs. The medial limb curves over the popliteus muscle to join with the oblique popliteus ligament, and the lateral limb ascends to blend with the capsule near the lateral gastrocnemius muscle. Oblique popliteal ligament, it is a broad, flat ligament of the posterior knee joint overlying the posterior joint capsule with a diagonal course. It provides insertion for the semimembranosus tendon, stabilizes the posterior aspect of the knee. Intracapsular ligaments and menisci include the anterior cruciate, posterior cruciate ligaments, medial and lateral menisci, and transverse ligaments. The anterior cruciate ligament arises from the medial part of the anterior intercondylar area of the tibia and passes upwards, laterally, and posteriorly to attach to the posterior part of the medial aspect of the lateral femoral condyle. It resists hyperextension of the knee, and it has low signal intensity on both T1 and T2 weighted sagittal scans. The posterior cruciate ligament attached to the posterior intercondylar area of the tibia and passes upwards, medially, and anteriorly to attach to the anterior part of the lateral aspect of the medial femoral condyle. The PCL is stronger than the ACL and infrequently torn. It resists knee hyperflexion. It is intensely hypointense on MRI. Injury to PCL is uncommon and best visualized by sagittal planes. This picture shows both anterior cruciate ligament and the posterior cruciate ligament. Regarding the menisci, the concavity of the tibial articular surfaces is partially covered and accentuated by 2 semilunar fibrocartilages, or menisci, which distribute weight-bearing stresses and improve stability. Each is attached peripherally to the tibia and to the capsule. The upper and lower surfaces of menisci are free. The menisci are triangular in cross-section. This is the medial meniscus, which is larger than the lateral meniscus. The medial meniscus has anterior horn, body, and largest posterior horn, while the lateral meniscus has anterior and posterior horns, which are relatively have the same size and a body. The anterior and posterior horns attach to the corresponding intercondylar regions. Menisci are poorly vascularized with only partial blood supply from the external surface. Hence, they heal poorly following trauma. Discoid meniscus. This is a normal anatomical variant in which normal open configuration of the meniscus is absent, predisposed to tears. MRI criteria of discoid meniscus are identification of the body of the meniscus on more than 3 contiguous sagittal 4mm slices, lack of rapid tapering from periphery to free edge of the meniscus, and abnormally wide meniscal body on coronal images without normal triangular configuration. This is the normal meniscus, and this is incomplete discoid meniscus, and this is complete discoid meniscus. Meniscal attachments. The meniscofemoral ligament from the posterior horn of the lateral meniscus to the medial femoral condyle is divided by the posterior cruciate ligament into the ligaments of Humphrey anteriorly and ligament of Risberg posteriorly. These are seen in 33% of sagittal images. The external aspect of the medial meniscus blends with the capsule and medial collateral ligaments, unlike the lateral meniscus, which is separated from the lateral collateral ligament by the popliteus tendon. Transverse ligament joins the anterior horns of the menisci. This is the transverse ligament, which joins the anterior horn of both menisci. Muscles of anterior aspect of the knee. Quadriceps muscles, including rectus femoris, vastus medialis, vastus lateralis, and vastus intermedius deeply. These form a broad tendon attached to the patella and continue to form the patellar ligament, which then attach to the tibial tuberosity. Muscles of the posterior aspect, including the gastrocnemius muscle, the plantaris muscle, and the popliteus muscle. Muscles of the medial aspect includes the sartorius, the gracilis, semitendinosus, and semimembranosus muscles. Muscles of the lateral aspect include tendons of the biceps femoris and popliteus muscles. Knee bursae. These are sacs around the knee joint filled with synovial fluid, help to reduce friction over tendons and bones. This is the suprapatellar bursa, prepatellar bursa, infrapatellar bursa, subcutaneous, and deep infrapatellar bursa, and anserine bursa. Now, regarding the radiological examinations of the knee joints, we have the plain radiographs of the knee joint, ultrasound, arthrography of the knee joint, magnetic resonance imaging, and CT scan. Plain radiographs of the knee joint, routine imaging include anteroposterior, lateral semiflexed 20 to 30 degree, tunnel, and skyline views. The joint space of the femorotibial compartments and patella-femoral compartments should range between 3 to 8 millimeters. Subcutaneous and infrapatellar fat pad, which is called Hoffa's fat pad, outline some of the soft tissue around the joint. Ligamentum patellae made visible by this way. Suprapatellar bursa is best seen when distended with fluid, seen as a soft tissue density above the patella. Normally, it is less than 5 millimeter on lateral view, 5 to 10 millimeters borderline, and more than 10 millimeters keeping with a joint effusion. This is AP view of the knee joint. This is the femur, patella, medial femoral condyle, lateral femoral condyle. This is the lateral tibial plateau, medial tibial plateau, anterior and posterior tibial spines, tibia and the fibula. And this is the intercondylar notch. Lateral semi-flexed view. In this X-ray showing the quadriceps tendon clearly, the patellar ligament, and the Hoffa's fat pad posterior to it. This is skyline view, which is used in trauma cases to assess for patellar fracture or subluxation and in patellofemoral joint diseases. This figure done by me, maybe it remembers you this view. Tunnel view, axial intercondylar fossa, used for assessment of a loose body and better delineation of the intercondylar eminence. Patella are, this is the AP view for the patella, and this is the lateral view for the patella. Fractures are usually easy to spot, and a bipartite patella, two-part patella, is a patella with an unfused accessory ossification center, typically at the superolateral aspect, should be not confused with patellar fractures. This lateral view of the knee joint showing fracture of the patella, and this is fat accumulated posterior to the tendon. Now, regarding the ultrasound, is essentially used for external structures of the knee, a valuable diagnostic tool in assessing the muscular, tendinous, and ligamentous damage. Classification of a mass, for example, solid or cystic, and guidance for injection, aspiration, or biopsy. This is suprapatellar scan plane, longitudinal, showing the quadriceps tendon and the femur and the suprapatellar bursa. And this is the patella. This is transverse view showing the rectus femoris, vastus lateralis, and vastus medialis, and the vastus intermedius. This is the infrapatellar scan.
Sotra.
يلا كمل.
So we record. This is the infrapatellar scan plane showing the patellar tendon, the Hoffa's fat pad, tibia, and patella. And this is lateral examination showing the lateral collateral ligament and iliotibial band insertions. And this is showing the medial collateral ligament, the green color, and the medial meniscus, purple color. Arthrography of the knee joint allows visualization of the synovial cavity of the joint and some or all of the associated bursae that may be connected with the joint cavity. The menisci are seen as filling defects, triangular in cross-section, whose upper and lower surfaces are outlined by contrast. Their bases are attached to the capsule. Some contrast may pass lateral to the lateral meniscus, which is less firmly attached to the capsule. Knee MRI is one of the more frequent examinations faced in daily recognized radiological practice. The field of view is small, 10 to 14 cm. Dedicated knee coil is mandatory to improve signal to noise. Supine position with leg in full extension. The knee is placed in 10 to 15 degree of external rotation, especially for sagittal view. 3 to 4 millimeter slice thickness for axial, coronal, and sagittal images. Image planes and sequences. Fat spin echo, proton density, and T2 weighted images in sagittal planes for menisci, articular cartilage, cruciate ligaments, patella. Steer sequence in coronal plane for marrow edema, T1 coronal image for collateral ligaments, bone lesions, T2 axial image for retinacular and patellar inner surface. 3D Fourier transformation imaging become popular as it provides high resolution and an acceptable signal to noise ratio, allow image reconstruction in any plane. In T1 weighted image, the image will be bright due to the fat in the marrow of the bone. And in T2, it appears low signal intensity. The cortical bone, menisci, mature fibrous tissue, including ligaments and tendons and calcifications, physiological and pathological, all are normally appear black in both T1 and T2 weighted images. While the fluid appears low signal intensity in T1 and high signal intensity in T2 weighted images, and the fat high in T1 and low in T2 weighted images. Items to be evaluated in sagittal sections: the menisci, cruciate ligaments, tendons, bones, and synovial effusion. In axial, retinacular ligaments, and in coronal, collateral ligaments. These are sagittal sections of T1 weighted MRI of the knee joint. Here the major muscles shown, the vastus medialis, the semimembranosus, the gastrocnemius, medial head. The medial meniscus start to appear in this section. How to differentiate between medial and lateral meniscus? We have some points to depend upon it, and in this case, the posterior horn of the medial meniscus is larger than the anterior horn, and this indicates that this is the medial meniscus. The other things, the absence of patella and the fibula. In this section, the posterior cruciate ligaments start to appear, which resembles the number 6 in Arabic digits. And here, the anterior cruciate ligament also appeared. This is the infrapatellar fat pad or fat pad. And this is the patella. Okay. Here the lateral meniscus started to appear. We know that this is the lateral meniscus by the size of the posterior and anterior horns, which are both in equal size. And the fibula is appeared here, and the patella started to appear. This is the body of the lateral meniscus. Now, regarding the anterior and posterior meniscofemoral ligaments, the anterior meniscofemoral ligaments is shown here, and the posterior meniscofemoral ligaments shown here posteriorly. And this is the posterior cruciate ligament, which divides them. Now, axial sections. The patella shows a large articular surface on lateral side and small articular surface on medial side. Hence, we can know the medial from lateral sides, and we can detect the lateral patellar retinaculum and medial patellar retinaculum. And there is the anterior cruciate ligament also appear here. This is the tibial collateral ligament, and this is the tibial collateral ligament. This is patellar ligament. And this is the posterior cruciate ligament. In coronal sections, medial and lateral collateral ligaments and anterior cruciate ligament and posterior cruciate ligaments on coronal cuts. This is the anterior cruciate ligament, and this is the posterior cruciate ligament. This is the tibial collateral ligament, and this is the fibular collateral ligament. The biceps femoris tendon and lateral collateral ligaments also seen here. Regarding the iliotibial tract, this is a thick band of fascia formed proximally at the hip by the fascia of the gluteus maximus, gluteus medius, and tensor fasciae lati muscles. The superficial layer is the main tendinous component and inserts onto Grady's tubercle on the anterior lateral tibia. And the deep layer inserts on the intermuscular septum of the distal femur. This is the iliotibial tract starting here and down, reaching the distal femur, and then inserts by its superficial layer to the Grady's tubercle on the anterior lateral tibia. Regarding knee CT scan, the purpose of a knee CT is the deposition of the bony structures and the morphology, furthermore, the demonstration and classification of fractures, as well as the visualization of the bone tunnels and implants in a post-operative setting. In the case of neoplastic, inflammatory, and infectious disorders, a knee CT is done to demonstrate bony erosions, osteolytic lesions, calcifications, and to evaluate bone matrix or soft tissue gas and their extent. And if MRI is contraindicated or metallic implants are present, a CT arthrogram of the knee can allow for evaluation of the articular cartilage and menisci in the setting of a previous repair and deposit ligamentous injuries. This axial cuts of CT scan showing the patella, the lateral condyle of the femur, the medial condyle of the femur, and the intercondylar notch. This showing the patellofemoral joint. This is the medial condyle of the femur. This is the patella, the base, and the apex. This is the coronal cut, showing that the medial and lateral condyles of the femur and the tibia. These are the tibial spines. This is the sagittal cut, showing the plateau of the tibia and the lateral condyle of the femur. And this is the medial condyle, which is larger than the lateral condyle. And this is the medial plateau. Thank you very much.
دكتورة فرح.
نعم أستاذ. عندنا رقم 1 medial femoral condyle.
medial femoral. دكتورة تبين. number 2.
نعم أستاذ. tibial spine.
tibial spine. تمارا.
نعم أستاذ. رقم 3 medial femorotibial joint. femorotibial joint medial aspect.
رغى السعدون.
نعم أستاذ. رقم 4 تيبيا.
تيبيا. نروح على دكتورة إيمان حميد.
رقم 5 فيبيولا.
فيبيولا. إيلاف الجابري. رقم 6. أحمد محمد جاسم.
نعم أستاذ، هذه الهيد أوف فيبيولا.
الهيد أوف فيبيولا. أوكي. حسين عبد الكريم. رقم 7.
نعم أستاذ، هذا تيبيو فيبيولا جوينت، بروكسيمال تيبيو فيبيولا جوينت.
سماء عطية. رقم
نعم
8.
دكتور this is the lateral femorotibial joint.
أوكي. زهراء عبد الحسين. رقم 9. رؤى.
نعم أستاذ lateral femoral condyle.
اكسلنت. رقم 10 ربع الإسلام.
نعم أستاذ. رقم 10 باتيلا.
فقط عندنا أخير وحدة رقم 11 بسيطة. زهراء عبد الحسين.
فيمورال شافت.
أوكي. أستاذ محمد كمل وياهم.
مروان موجود؟ مروان
كل صوت أستاذ واحد.
مصطفى خضير. رقم 1.
نعم أستاذ. رقم 1 هو هذا T1 weighted MRI Sagittal view. رقم 1 the quadriceps tendon.
محمد خضير. رقم 2.
نعم أستاذ. هذا اللاترال منسكس. posterior horn of lateral meniscus.
جيد. هدى رعد.
نعم أستاذ، هذا proximal tibiofibular joint.
هديل. رقم 4. هديل كريم. ياسمين.
العفو اوكي.
neck of the fibula.
نعم.
neck of the fibula عمو.
زين. آخر شيء ياسمين فلاح.
نعم أستاذ. هوفاز فات باد.
عندك بعد؟ هاي هي.
هاي أستاذ.